So why don't you take us through some of the pre-op consideration? How do we work these patients up when we're talking
So
about
we
it?
looked at kind of some of the data, but I mean, as optometrists, we're often involved, as the first and last touch point when we're in a clinic, but also out in community. Patient selection is really important. We've talked to you about what this lens is, and we want to know kind of who does well with it. How do you select it? And I think, as Nick mentioned, I think we started with one very specific demographic, and as time's gone on and we've seen these outcomes, I think that's really, really opened up, which is key. We're going to talk about the pre-op workup and some of the things that are important. So you want patients that are refractively stable, right? That's not unique to this procedure. This is pretty much any refractive surgery you want to do. The last thing you want to do is treat a moving target. Typically, we're looking for on-label use. So, pre-presbyopic patients between 21 and 45, stable with enough anterior chamber depth. Endothelial cell density, obviously there's age norms and you want to look at, what's outside of those norms. So is something abnormally low for that person's age? Is the quality of those cells? Can you see guttae or something really, abnormal on examination? Nice wide open angles on gonioscopy. If they do have keratoconus, that needs to be stable. So often this is actually a really great application for EVO ICL, is those patients that have been cross-linked. Obviously, you're not going to go back and laser them, and they often have really strange refractive error. And these are some of kind of the happiest patients. But like every refractive procedure, the key is just having a nice healthy eye to kind of go into.
Kind of talked a lot about this already. The white to white, I think, is the one thing that if you work with EVO, that is directly going to be linked to your diameter. That's going to be linked to the size of the ICL, which will then impact your vault, which would impact your angles. So the white to white measurement is, how do you guys do it in your clinic? I mean, do you do white to white? Do you do
we use an orb scan, but I mean, there's multiple different things. And I think on one of our slides, you're going to see it can be measured with an orb scan, which is a form of topography that really isn't used by many clinics. So we're a little bit lucky that way. And I think it'll die at some point. It's not technology we plan to, redo over again. So we use a pentacam as well. We've used calipers. You can use, people use UBMs, which is not strictly white to white. You can use various forms of anterior segment OCT. So when we talk about sizing, so we talk about two things with the ICL. One is the power. So we mentioned, different forms of refraction and why that's important, why the manifest is so important. But also with the sizing, in Nick's case, he was talking about the size being too big, too small, and how that affects the vault. And I think that is something that, is very, very unique to ICLs. And the combination of the white to white and the anterior chamber depth is how we get to that size. And so that's kind of what we have here. So you have to assess your anterior chamber. And looking at kind of the different settings there, again, making the distinction between internal and external, because if it's the external, you're going to, have the wrong measurement because you're going to add an extra 500 plus microns there. So those are always really important.
Yeah, the ciliary sulcus is what we're trying to measure.
Yeah.
I mean, and it's hard to measure it. It seems easy. Well, why don't you just use an OCT or an ultraviolet, some sort of device to measure that? But the other problem with the ciliary sulcus is it's not perfectly symmetrical, and there's some variability there, and it's not perfectly smooth. So you can put the lens in, and it can kind of rest on a crypt or a valley and kind of sit. There is irregularities to it. So that is the challenge.
Okay, right? Like with this kind of when we think about sulcus placement, like I said, I work in anterior segment, and you think about things like UGG syndrome, for example. You put something in the sulcus, this is a risk, right? And those are with kind of hard lenses. With this kind of soft material, you don't need to be kind of exact. As you mentioned, it's going to kind of settle in where it's going to settle in, and it'll find its groove and typically do really well with that. There's for white to white here, there's a bunch of different correction factors that can be used. There's actually a paper that came out very, very recently and like really hot off the press. But I think in most clinics, like for you guys, what do you use? And do you have a correction, like a fudge factor, I guess?
Yeah, we use the pentacam. So Micheletti was the one who had the paper, and he talked about different devices and kind of a fudge factor on which devices are more accurate than others. And they're all accurate if you use the same device. You kind of have to have a little bit of a comfort with the device. We use the pentacam, and we're comfortable with that, and we kind of know, how we need to adjust our size based on that. But if you use an orb scanner, if you use just manual calipers, I mean, that's an old school way, but that's how they did it with the FDA trials. Using the same method over and over again, you get a feel for how it works. It's like using the same, it's like my golf clubs. Like I use the same clubs every single time. You get a feel for, well, how far into the woods am I going to hit this one? You get the feel for your own equipment. And that's really, I think, the key with it. There's a fudge factor with it.
Well, it's also so forgiving that, like, really, we stress over it just because we all have, that type A personality that serves us well in work, but also, like, we know that it's going to be okay.
Yeah, yeah. Let's flip it. Let's flip it over then. So we go through surgery. Our surgeon colleagues do a fantastic job. Lens goes in. Everything goes well. What are we
We'll
looking at
gloss
now?
over that part,
Yeah, yeah, yeah,
A
yeah.
minor
That's easy.
detail. We'll get back to us, back to the OD, heavy lift. This is how we measure vault. And I think, when I train our community ODs, when we have them come in, and often have them shadow, have an open door policy, and come and have a look at a few of these, because vault, is very unique to the EVO ICL. So you look at kind of the distance there. You can see it in between the slit lamp beam. I don't know if we can even see it in there. So whether it's a normal vault, whether it's shallow, whether it's a high vault. So looking, where the placement is of the ICL, and you can just see this at the slit lamp. You don't need any fancy equipment. Sometimes when we're running training, we'll actually do measurements like on an ASOCT, but you really don't. And once you see a few of these, you really kind of get a feel for that. You look at the distance between the beam there. I don't know if
There's a scan right here. Take a look at that one. So
that's
that's
a great
obviously
one to.
So, I mean, Anu, let me ask you this then. So, if you've got a patient who has a vault, so we do it down and dirty. You're comparing it to the thickness of the cornea. You assume your cornea is about 500 microns, right? 500 is kind of ideal. The lens is extremely forgiving, though, so you can go as low as off-label, like maybe borderline label. If you're down to 50, leaving it in there is fine. All the way up to as high as you want. If you have a high vault, what's the next thing that you're going to look at?
So looking at your higher vaults, you want to look at the angle,
Yep.
and that's really what you're treating. You're not treating, like, the vault is something we measure, we track, that kind of thing, but we're treating the vault. So if there's no issue there, if the IOP is okay, the angle's okay, you're not worried about anything.
Yeah,
We can
it's
watch
like
it, we can feel
glaucoma.
comfortable.
I
Yeah,
mean, glaucoma, you're not treating the pressure,
yeah,
you're treating what the pressure is doing, right?
that's right.
Your vault is your
100%.
risk factor, but the angle is what you need to keep an eye on. So the vault is just how we track it. That's how we look at it, just like we measure pressure. But if I got a patient who's got a pressure of, 15, but for them that's way above target, that's still a problem.
That's
And
right.
so that's what you're treating. So let's talk a real quick. We got a couple minutes left here. We'll talk about the why, and I kind of hinted at that. Why are we improving vision? Let's talk about optics. We're gonna go back to these ray diagrams. I know everybody loves the ray diagrams from their optics days back in optometry school. So if we have an incident ray, we've got this just simplified system: our contact lens, our cornea, our crystalline lens onto the retina. Well, there's a reason why high myopes like contact lenses better, right? It's retinal minification. So if we correct the vision in front of the corneal plane, that is going to shallow out our incident angle, and we're going to be left with a certain retinal image size. Well, if we can adjust that, right? If we can correct vision on the corneal plane, well, that's going to give us a much greater retinal image size. Ask anybody if you're a myope out there, you probably like when your contact's better, assuming they feel comfortable, because of the increased retinal image size. It's just crisper vision. So that theory, the reason that myopes tend to like that better is because of the nodal point. The nodal point sits about 17.2 millimeters in front of the retina, right at the anterior crystalline plane. So if you can correct vision better or closer to that nodal point, you're going to improve vision. And so that's why our patients do actually get improvements in their vision. And they can actually, they come in, they're 2025 plus or so. If you've got a minus 8 individual, they leave their 2015. That's very, very realistic. So we talked a little bit about why LVC isn't always the best choice. There's several reasons. I mean, there's thin Ks, ocular surface disease. I mean, patients who come in with dry eye, contact lens intolerance, and then corneal irregularity. I knew you mentioned it. You can do ICL with keratoconus. And
I think those ones are great because they don't really have another option. But I mean, let's think about those ones where they come into your office and they've just got those weird topographies. I think Dr. Blumenstein calls them like FLT, funny looking topographies, which I love, and I'm totally stealing that. But, they're just a little wonky. They just make you feel your spidey senses tingling a little bit. For those of you that use a pentacam, you've got your Balin-Ambrosio scale, and it's not quite right. So it doesn't have to be this kind of like super bad, like a 400 micron cornea is, I think of kind of an obvious one, and same thing with the topography. But those just, not quite right. Why take the chance?
Yeah. And it's dose dependent. So
Yes.
the more prescription you have, the more ablation you need to do.
And
ICL, that lens is, the higher risk.
Yeah.
ICL, it's the same size lens pretty much going in every single time. So you don't really have to worry about that.
Well, you're not worrying about severing corneal nerves. Obviously, nobody would say that an ICL is, of course, like the treatment for dry eye. Of course not, right? But often these patients are contact lens abusers and overwearers and what have you. We're all on screens too much. So you take that out of the equation, no matter what refractive procedure you do, you've taken the offending factor out. But by operating on the cornea, you're probably going to take an at-risk eye and kind of tip it over the edge a little bit. Whereas you go inside the eye, you're reducing that risk further, which is great.
Yeah, that's why I've got the question mark next to the word invasive here.
Yeah.
So it doesn't seem invasive LASIK because you're not cutting into an eyeball, but you are definitely permanently altering a cornea. So less invasive, or is it even more invasive?
Yeah, it's
arguable.
a really tricky word that way, right? When you think of something as not being reversible, it really does seem kind of worse. But I mean, when you traditionally think of intraocular surgery, which of course, ICL is, it's one of those things. I think you could easily make the argument either way, I think, and neither would be wrong, in my opinion.
Yeah. Last point here, again, we already talked about this, but at some point, if you live long enough, these things are coming out. They come out. I mean, you can see the crystal clear picture right there. And I've heard from plenty of accounts that these lenses come out in the same condition that they go in. They are completely biocompatible. They don't sclerose down. They don't they come out very, very relatively easy. I've never removed one. I'm not a surgeon. But from what I understand, they come out very, very easily. And it doesn't impact cataract surgery down the road. So it doesn't affect your calculations. LASIK does. I know you've seen refractive surprises. I have too. Those are very unhappy patients because those patients have very high expectations. This does not affect them. We can account for this, and we have the full range of premium lens on the table for patients. You're future-proofing your eyes by doing a procedure like this instead of laser vision correction.
There's a lot to love for sure.